Hello, everyone. My name is Andrea Kossler, and I'm the Director of Oculofacial Plastic and Orbital Surgery and Associate Professor of Ophthalmology at the Byers Eye Institute at Stanford University School of Medicine in Palo Alto. And I'm joined today by one of my brilliant and wonderful colleagues, Dr. Prem Subramanian, who is the Clifford R. and Janice N. Merrill Chair and Professor of Ophthalmology, Neurology, and Neurosurgery at the University of Colorado School of Medicine. And he's also the Vice Chair for Academic Affairs and head of the Neuro-Ophthalmology Division at the Sue Anschutz Rogers Eye Center in Aurora, Colorado. Welcome, Prem. I'm really excited to speak with you today.
Thanks, Andrea. Really happy to be here with you.
Well, great. So today we're going to be talking about some really exciting advances in the field of thyroid eye disease. We're going to talk about new research and clinical trials in emerging therapies and drug discovery in thyroid eye disease. And this is really one of my favorite topics because there's so much exciting innovation. And I am really excited to learn from Prem today because I always learn so much from everything he has to say. So I'm excited to interview you today. So I'm going to just kick us off now, and I'm just going to first of all, give you an easy question here. So we know that teprotumumab has been around since January of 2020, and we all have a little bit of experience at this point after the last 3 years using this as an IV infusion. But there's been a lot going on behind the scenes. So can you share with us other clinical trials and other discoveries with teprotumumab that are currently ongoing?
Just wrapped up was a trial looking at patients with a longer duration of thyroid eye disease, 2 to 10 years, as well as a low CAS, 0 or 1, to see what the efficacy of teprotumumab might be. Some top-line data suggests that it was effective, and we're waiting to see the full manuscript and all the details published. And similarly, there's a trial that should be wrapping up soon that looked at the relative benefits and side effects of giving 3, 6, or 12 months worth of therapy in patients with more acute, newer onset thyroid eye disease. So we'll see what that shows us and whether that changes anything. And then a study that is just getting going now is a subcutaneous infusion of the drug as opposed to the IV infusion. And so that clinical trial is just launching. As you mentioned, we all have lots of experience with this drug now, and several of us, you included, are doing ongoing studies at institutions or multiple institutions to look at questions regarding efficacy, recurrence, and treatment of specific problems like double vision.
It's so amazing how much work has been done on teprotumumab. So we know that, of course, it's been shown to be effective in active, moderate to severe thyroid eye disease. And as you mentioned, now there may be some efficacy in patients with chronic low CAS disease, and there's a lot of exciting things ongoing. So we've talked a little bit about teprotumumab, which is an IGF-1 receptor inhibitor, but what can you tell us about research that's being done regarding the role of the T lymphocyte and the cytokines, which are so important in the pathogenesis of thyroid eye disease?
So the role of T cells and T helper cells, in particular Th1, Th2, has been postulated for a long time in driving thyroid eye disease and an imbalance between these populations. Th17, and specifically Th17.1 cells in particular, have been identified recently, potentially being important because they secrete gamma interferon as well as IL-17A, and these again may be driving the disease. Interestingly, gut microbiome even may alter the Th17 population imbalance. Remember, these cells are normally present in all of our bodies, and it's the imbalance in the populations that drives disease. And so based on that, there is a study that's just getting going looking at the potential for inhibiting CD3 with a drug called otelixizumab, which has been in trials for type 1 diabetes and other autoimmune disease, and to see if modulating these T cell populations, preventing activation of T cells, could lead to a less pro-inflammatory state and downregulate thyroid eye disease from a very different angle than something like teprotumumab, which is targeting antibody-mediated or primarily B-cell-driven activity.
That's so interesting that you mentioned how IL-17A can affect the microbiome. Do you think that is associated at all with recommendations to change diet or perhaps to cut out gluten? Like, do you think that we can also decrease inflammation through what we eat?
It's a really interesting idea. I think the research is very preliminary, but this idea that gut microbiome drives thyroid problems and changes thyroid and then thyroid eye disease conditions is absolutely very interesting.
Yeah, I love that. There's so much that we still have yet to fully understand. Um, so I have a couple more questions because there's just so many drugs out there that are being investigated. And as we learn more and more about the pathophysiology of thyroid eye disease, we're learning that there may be more targets that we can hit and treat this disease. So we've talked about IGF-1 receptor inhibition. We've talked a little bit about inhibiting the T cells. But what can you tell us about some of the other interleukin modifying agents that are being studied, and maybe why it would be important to target some of these interleukins that we know play a role in the pathogenesis of thyroid eye disease?
In the course of the acute disease with these inflammatory cells populating the orbit and marginating in from the circulation, there are, as you mentioned, interleukins that either drive up this process or help to reinforce it so that the inflammation increases and you get increased water, increased attraction, chemoattraction of other pro-inflammatory molecules and pro-inflammatory mediators. And one of the main drivers may be IL-6, and it's overexpressed in tissues from patients with thyroid eye disease. And inhibition of the IL-6 receptor has been shown in some small case series of patients with thyroid eye disease, some of whom failed other therapies, to be effective in down regulating their CAS in terms of even reducing their proptosis, maybe improving their motility. And so there is currently a study that is going on to look at an IL-6 depleting antibody that may be effective without inhibiting the IL-6 receptor itself. There is also a study with a drug satralizumab that is an IL-6 receptor antagonist approved for other conditions, not thyroid eye disease, that is being studied to see if it is effective. So we have two different drugs, one targeting the molecule itself, IL-6, and then one targeting the receptor, that are being studied to see if that could be effective, again, in a completely different pathway than drugs that are available now. And then IL-11 is an interesting molecule because its levels are increased in thyroid eye disease tissues as well. The IL-11 receptor seems to be preferentially expressed on orbital fibroblasts, and perhaps more so in patients who have TED. And so IL-11 has been implicated in the development of fibrosis in other disorders such as idiopathic pulmonary fibrosis. And so there is an inhibitor of IL-11 that is being studied both for pulmonary fibrosis and for thyroid eye disease, with the idea that down-regulating IL-11 expression or blocking its receptor could, again, not just affect inflammatory activity, but decrease that pro-fibrotic action that it has.
Yeah, I'm really excited about some of these cytokine and interleukin modifying agents because I agree with you. I think that we've come a long way when it comes to treating the active inflammatory phase of the disease, but in that more fibrotic end stage or chronic disease, it's interesting to think that perhaps an interleukin 11 inhibitor could help those patients that are dealing with more fibrosis or end stage. So we'll have to wait to see what these studies show. But similarly, what can you say about other drugs that are targeting fibrosis, such as rapamycin, which is currently being studied as a second-line treatment for thyroid eye disease? And maybe tell us a little bit about how that might work and why we might consider that in thyroid eye patients.
It's really interesting with rapamycin because it was tried first because of its anti-inflammatory activity. It's used in post-transplant patients typically for immune suppression. And so it was tried just in the as part of our armamentarium of drugs to just reduce inflammation and reduce that immune response. But then it was observed that it may have a benefit on the fibrotic state and on the fibrotic changes. Unexpectedly, patients were seen to have maybe better extraocular movements. And so there was a study published just this month that showed that patients who were given rapamycin in comparison to mycophenolate mofetil, and they were all given corticosteroids, the ones who were given the rapamycin had more improvement in their motility and seemed to have a less fibrotic phenotype. And then there was a study published with in vitro studies of orbital fibroblasts, so purified away from any inflammatory cells, showing again that there was a decrease in fibrosis with rapamycin that clearly was not related to any kind of immune suppressive activity. So it's an exciting and interesting agent. It's been around a long time. It's pretty well tolerated, and our colleagues in other fields have a lot of experience using it. So I think, as you mentioned with the IL-11 drugs, this is a potential way of treating our patients in a multimodal fashion that's not reliant on one pathway alone.
That's such an important point. I think that, when teprotumumab came out, it might have been thought that, oh, this is going to be able to treat all patients. But the truth is that thyroid eye disease is such a heterogeneous disease, and patients have different phenotypes, and they probably have different drivers molecularly that's driving their disease. So now that there's all these treatment options, it's really interesting to see how we will combine and use them all so that, we can really treat the different aspects of each individual patient and provide more customized treatment based on, the phase and stage of their disease. So just a few more drugs that can help us for those really challenging to treat fibrotic patients. And as you mentioned, improving double vision, I think, is one of the most important things that we can do for our patients because it's so debilitating. So really exciting to hear about those treatments. I'm going to move on to talk about a couple drugs that are currently being investigated that I think we have a little bit more familiarity with, and that's the VRDN-001 molecule, which is the anti-IGF-1 receptor monoclonal antibody. So if you can just tell us a little bit about that drug and how it's different from teprotumumab, which we know is also an anti-IGF-1 receptor monoclonal antibody. And we know that the company has released some top-line results. So if you want to share with us a little bit about how that drug is doing in their very early proof of concept studies. And, there's a lot of drugs that we can talk about in the anti-IGF-1 realm. So if you want to give us your summary on how those drugs are working and how they differentiate from each other.
In that space, the VRDN-001 is probably farthest along. And as you mentioned, this drug is also an IV infusion given every 3 weeks like teprotumumab. The company has published some data suggesting it is a complete inhibitor of the IGF-1 receptor, whereas teprotumumab is a partial inhibitor that could make it more effective. And they released some top-line data in subjects who had just 2 doses of drug and showed what seemed to be a pretty impressive response of proptosis and reduction in their CAS. It was a handful of patients, so we really need to see what comes out of the larger phase 3 clinical trial that is ongoing right now. It is interesting, though, and they also have a subcutaneous drug that they are working on. Lonigutamab is already a subcutaneous small volume injected IGF-1 receptor antagonist or blocker that is thought to have an even greater affinity for the IGF-1 receptor, and it is suggested that a subcutaneous injection of any of these drugs, because it would then have a lower peak plasma concentration, might then have a better side effect profile. So that drug is also now in trials to see how it stacks up against what's out there. And then lincitinib is an oral small molecule that, again, blocks the IGF-1 receptor. And what's interesting about it as an oral small molecule, potentially daily dosed drug, is that you could modulate the levels of that drug a little more easily in the system than you can something that is infused or even given subcutaneously. So certainly new agents coming along that the role for which is not clear yet. They're still being studied. They're still in early phase clinical trials, but opening up the space even in IGF-1 receptor antagonism that could make it more effective in our patients.
This is such great news for our patients because now we're talking about oral and subcutaneous and intravenous infusions, and also many different, we've so far mentioned 4 different IGF-1 receptor inhibitors, each of them that work slightly differently. So it's really exciting that there's so many drugs that are being studied, and so far the results seem impressive with some short-term results so far. So I want to just move away from the IGF-1 receptor inhibitors for a moment. And you actually touched on something that's really important, which is the adverse events. And so we'll have to wait and see how these different drugs stack up against the adverse events that we know of with teprotumumab, and if perhaps we can find a drug that is maybe safer and as effective or maybe more effective than teprotumumab. But moving away from the anti-IGF-1 receptors, I want to talk a little bit about batoclimab, which is another drug that's being studied for thyroid eye disease. So if you can just tell us a little bit about how that drug works and tell us about the clinical trials.
This is a drug that works in a completely different way by inhibiting the neonatal FcRn. And what that means is that the FcRn part of the antibody is used to protect antibody as it goes through a normal recycling through cells and re-enters the circulation. And if that is blocked, then the antibody is more likely to be degraded once it is taken up by the cellular systems. So this drug depletes antibody in a more general way, but the idea is that it takes circulating antibody like TSH receptor antibody or TRAb out of the circulation more rapidly so that that antibody, which is the primary driver for thyroid eye disease on the orbital fibroblasts, so that molecule is taken out, that antibody is taken out more rapidly and ideally will downregulate the process. And so this is a proven strategy in some other autoimmune diseases like myasthenia gravis, where there are FDA-approved drugs that operate on this mechanism. And so this drug was briefly had its clinical trial stopped because there was concern over serum cholesterol being increased, but that's actually an expected effect because it depletes serum albumin. That is now considered not to be a serious problem or is being monitored, and this drug is now back in a phase 3 clinical trial. So we'll see what happens. Again, because it's a completely different mechanism, it may be appropriate for some of our patients who are not good candidates for some of the other drugs that either are available commercially or being studied.
Yeah, this is another drug that I have my eye on. It's interesting to think that you can just shut down the pathogenic IgG and perhaps its use earlier in the course of the disease. I know this company is also even looking at treating Graves' disease patients before they develop thyroid eye disease. So we have a lot to learn on this drug and so many others. But I want to wrap things up here and just give you the floor to let us know if there are any other drugs that I didn't cover here or any other potential treatments that are on the horizon for thyroid eye disease that we should all be looking out for.
You mentioned something that could treat Graves' disease as well as thyroid eye disease, and the holy grail of that would be something that targets the TSH receptor antibody and takes it out of circulation specifically. And if there is a molecule that is developed that could do that, I think that would be a very powerful way for treating our patients. And again, give us another drug. I think another thing to keep in mind is there's a lot going on and we don't understand everything about it, and some things will fail. There was a trial of a drug to block IL-17, which seemed really promising, but then that trial was terminated because it was not going to reach its endpoint. And so it's a cautious time as well, because we can be excited about some of these drugs and they can make sense from an in vitro or even a phase 1 standpoint, but then it remains to be demonstrated down the road if there is true clinical efficacy. The final thing I would say is that as we alluded to, it's unlikely there will be a one and done drug for all of our patients, and they may need treatment with different agents at different times in their disease course.
I completely agree with you. And I've learned so much from hearing you talk about drugs that I already know about, but you teach me more every time I hear you explain, your view on them. So we've covered that not only are there ways to just stop inflammation like steroids that we've been using for decades, but now more targeted treatments towards the IGF-1 receptor, which we know is such an important autoantigen in this disease, but now also looking at different interleukins, looking at lymphocytes, looking at fibrosis in general, and all of the work that's being done on just decreasing pathogenic IgG. So it is a really exciting time for thyroid eye disease. There's many studies ongoing and so much more that we have to learn. But I learned a lot from you, and I want to thank you for all the wonderful answers and the discussion. And I want to thank everyone that's listening for your time and attention. I also want to remind everyone, remember to take the post-test and the evaluation so that you can receive your CME credit. And also please tune in for additional episodes within this podcast series. Thank you so much.